It is an honor to welcome you all today and to have the opportunity to share with you a brief overview of anaphylaxis and its main treatment, which is intramuscular adrenaline, and giving you some clues on how and why adrenaline is recommended as first-line treatment for anaphylaxis. I am Antonella Muraro. I am an allergist and pediatrician leading the Food Allergy Center at Padua University Hospital in the northeastern part of Italy. I was EACI president, and I am still chairing the EACI Food Allergy and Anaphylaxis Guidelines Project and the Guidelines Committee. Besides having received a fee for this lecture, I am consultant for Regeneron and received honoraria from Nestlé Purina, Beatrice, Nutricia, Nestlé Health Institute e Immune DVB Technologies for lectures. Today, we will together go through the anaphylaxis burden, definition and diagnosis, the adrenaline as my main treatment, the role of adrenaline autoinjectors, and why to autoinjectors. And this is a flyer and the main theme of the European Academy Anaphylaxis campaign held some years ago, which underlined that anaphylaxis is an imminent danger in our lives. Actually, anaphylaxis is a severe life-threatening systemic reaction with incidence range from 1.5 to 7.9 for 100 person years. And admission with anaphylaxis increased over the last 2 decades. However, the huge difference in incidence reflects the difficulty to get the correct epidemiology of the acute episode. The main triggers are food, drugs, and interesting, but in up to 20% of the cases, the elicitors are not identified. And here you can see how the main elicitors vary according to the age. So food triggers are dominant in the pediatric and young adult age, and then we have drug allergy and incest. Most of these triggers evoke anaphylaxis on the base of immunological IgE-dependent mechanisms. But we know that there are other mechanisms which are non-IgE dependent, which are involved in radiocontrast, non-steroidal inflammatory diseases, dextrose, and biological agents, anaphylactic reaction, and also mechanism due to direct mast cell activation, such as the physical factors, ethanol, and medication as well as idiopathic anaphylaxis, where some triggers were not identified. Due to the difficulty to identify anaphylaxis as the symptoms usually overlap with many other diseases, in 2006, a second symposium held at NIH Institute in Washington, D.C., established clinical criteria in order to get 90% of the cases at the emergency department with a 95 limit of confidence. So it was agreed that anaphylaxis is highly likely when any one of the following 3 criteria is fulfilled. First of all, involvement of skin and respiratory tract and sudden fall of the blood pressure. The second criteria includes history. So in order to catch as many cases as possible, the history of exposure to a likely allergen for that given patient is included. So you can have the same symptoms, but here we have also the gastrointestinal symptoms included, respiratory or respiratory and gastrointestinal and respiratory, including the cardiovascular symptoms. In addition, in the third criteria, they tried to catch the 10% of cases which don't show any cutaneous involvement, any respiratory involvement, but they have only the fall in the blood pressure from minutes to several hours. And here you can find the blood pressure fall in infants as well as in adult person below which the drop should be greater than 30% decrease from that person baseline. So the assessment of the history of anaphylactic episode should also evaluate the time elapsed between exposure and symptom onset and the evolution of symptoms and signs. And this should be evaluated in order to diagnose properly and exclude in infants the foreign body aspiration, the congenital malformation of the respiratory tract, gastrointestinal tract, and apparently life-threatening, even sudden infant death syndrome. And in middle age and elderly adults, infarction, myocardial infarction, pulmonary embolus. Adrenaline is considered the first-line treatment for anaphylaxis by all the academic institutions across the world. So it is even a worldwide treatment already recognized by the World Health Organization. And it is also recommended for vulnerable patients such as pregnant women, infants, and elderly. And the assessment of the cost of benefits outweigh the cost, and the benefit is saving life. Intramuscular adrenaline is the preferred route of administration. This is an algorithm developed in the context of the Food Allergy Anaphylaxis Guideline Project, where you can see that giving intramuscular adrenaline is the first mandatory step for any of the symptom presentation symptoms for hypotension, collapse, stride, or wheeze. And then you can consider to repeat the dose after 5-10 minutes if there is no benefit or even worsening of the action. Intramuscular adrenaline has a very good safety profile, and other ways than intramuscular should be evaluated for their proper use. Subcutaneous inhaled adrenaline is not any longer in place. It's not recommended for anaphylactic use, but for the IV use, this should be considered with caution. So it should be monitored. The use should be monitored by emergency physician and anesthetist in an adequate setting with continuous electrocardiogram, pulse oximetry, and frequent non-invasive blood pressure, as this may cause life-threatening hypertension, myocardial ischemia, and arrhythmia. So, patient may have for sure transient pallor, palpitation, and headache further to the administration of intramuscular adrenaline, which are easily overcome in half an hour. Intramuscular administration provides a response in less than 10 minutes, 8 to 10 minutes, both on the heart rate, systolic, and diastolic pressure. And here, adrenaline has an effect on alpha-1 receptor, causing peripheral vasoconstriction, so reversing the hypotension and mucosal edema, beta-1 receptor by increasing both the rate and force of cardiac contraction, so reverse hypotension as well, and beta-2 receptor, reverse bronchoconstriction, reducing the release of inflammatory mediators. So adrenaline must be administered to all patients experiencing anaphylaxis, and those with clinical features that are likely to evolve into anaphylaxis, as there are no absolute contraindications to treatment with adrenaline in a patient experiencing anaphylaxis. Benefits, as we said before, outweigh the risk, both in the elderly and in patients with pre-existing cardiovascular disease. The second-line intervention means that the trigger of anaphylaxis episode must be removed. We should call for help immediately after having stabilized the patient. The patient should be post supine with elevated lower extremities if they have a circulatory instability, and sitting up if they have respiratory distress in recovery position in field conscious. High flow oxygen should be administered by face mask. Intravenous fluids crystalloids should be administered with bolus of 20 milliliters per kilo in patient experiencing cardiovascular instability, and inhaled short-acting beta agonist should additionally be given to relieve the symptoms of bronchoconstriction. Third-line intervention includes oral H1, H2 antihistamine, which are intended to relieve cutaneous symptoms. Systemic steroids may be used that can reduce the risk of late-phase respiratory symptoms. This has not been confirmed in evidence-based evaluation, and it makes more sense if high-dose nebulized glucocorticosteroid are considered for upper way obstruction. Parenteral administration of glucagon, according to the guidelines, may be useful in treating patients with anaphylaxis which are responsive to adrenaline in order to increase the threshold for response, especially in those taking beta blockers. So, in summary, self-injectable adrenaline is the first drug of choice for any suspicion of anaphylaxis, and its administration should not be delayed. Secondly, we could consider, depending on the symptoms, inhaled beta-2 agonist and H1 antihistamine. And steroids are really in the gray area of any emergency kit. This is the composition of the emergency kit which should be provided to the patient after the acute episode. And steroids are really in the gray area, as their administration can even delay the prompt administration of adrenaline. So antihistamines don't work fast enough, and you have here the time to 50% suppression of histamine-induced flare of two types of antihistamine, and here steroids again don't work fast enough, and we have from 30